Hey radiotherapy students, in today's video we're going to work through a rectum radiotherapy image match case step by step, and I'm going to do this with the assumption that you have no knowledge of radiotherapy. Now this is a really useful case for students because it shows that image matching is not only about just lining images together visually, but it's all about clinical decision making. So in other words, we are not only asking, do these images look similar, but also asking, is this patient in a safe and acceptable position to receive radiotherapy treatment today? So through this case, I'm going to explain the patient diagnosis, the treatment prescription, the meaning of the structures we're matching to, and we'll also walk through with you why this patient should not be treated for the current image. So let's start with the patient information. We have Sanvi Chopra, age 63, and the diagnosis is CT2N1M0, rectal adenocarcinoma. Now, let's break down these terms because these are very important. So, rectal adenocarcinoma means that cancer that starts in the glandular cells within the lining of the rectum. So, the rectum is the final section of the large bowel, just before the anus. And adenocarcinoma is the most common type of rectal cancer, and it develops from the gland-forming epithelial cells. Now, let's explain the staging in a bit more detail. So, the C in the CT2 means clinical staging. So, C, clinical staging. That means that the stage has been determined using a clinical information such as scans, physical examination, and investigation before treatment. And T2 means the primary tumor has grown into the vascular wall of the rectum, but it has not grown through it or into the surrounding tissue, so it's still within the rectum. And N1 means that there's evidence of regional lymph node involvement. So in simple terms, the nearby lymph nodes are also affected. And finally, N0 means that there is no distance metastasis. So there's no evidence that the cancer spread to distant organs such as the liver or the lungs. Now, you may be asking yourself, why does understanding this, why is it useful in terms of image match, and why do we need to know this? This is because the stage and the location of the disease tells us what needs to be covered by the treatment. So if the tumor is in the rectum and the nearby lymph nodes are involved, then the treatment volume is not just a visible tumor. So we also need to account for all the areas that may contain microscopic diseases, especially the relevant nodal regions. And that is why the rectal radiotherapy plans can include multiple target volumes and nodal regions. And that is exactly why image matching needs to be done carefully. Now, let's look at the treatment prescription. The patient is having radical VMAT with 45 grays in 25 fractions to the perirectal, presacral, and internal iliac nodes, with sequential boost to 50.4 grays to the primary tumor and mesorectum. Now, there's a lot of important terms here, so let's break it down a bit more. Okay, so firstly, we have radical treatment, and that means that the intent is to treat the disease definitely, with the aim of long-term control or cure. Rather than relieving the symptoms, we are aiming to deliver the radiotherapy to treat the cancer. So that means that the accuracy required are especially important in this case because we want to deliver the prescribed dose to the target while also protecting surrounding healthy tissues. Next, moving on to VMAT. VMAT stands for volumetric modulated arc therapy. Now, VMAT is a type of external beam radiotherapy where the treatment machine rotates around the patient while delivering radiation. And as it rotates, the machine can continuously adjust the shape of the beam, so that's the MOCs, to be more specific, and the dose rate and the speed of the gantry rotation changes as the gantry rotates around the patient. Now, this allows for highly conformal dose delivery, which means that we are much more accurate as we're delivering the treatment, and that means that the high dose region can be shaped closely around the tumor and the target structures. So that means we can deliver a high dose per fraction because we're much more accurate. So why is this important in this scenario? because highly conformal plants like the VMAT can be more sensitive to rotation errors and anatomical change. So for instance, if there's any sort of change within the body of the patient, that can be highly affected as we're delivering high radiation through the VMAT. So if the patient's pelvis is rolled or there's any internal anatomy that which has changed, the dose distribution may no longer fall where it's intended. So even if the image looks close enough at first glance, the actual delivered dose could be compromised. So let's look at GY. GY stands for gray. As some of you may already know, this is the unit absorbed radiation dose. So that's a universal unit which indicates how much dose a patient's taking in. So no matter if you're in any other continent or America or Asia or you're in Europe like I am right now, gray is a standard unit used everywhere in radiotherapy. So when we say 45 grays in 25 fractions, that means that the total dose is 25 gray. Okay? So 45 GY is 45 gray, delivered over 25 separate treatment sessions called fractions. So the patient is expected to come in for 25 days of treatment or 25 fractions. So as I just mentioned, a fraction is simply one individual treatment appointment. So in this case, this patient is currently in the 11th fraction out of 25, which means that they're almost halfway through the treatment. Now, fraction is very important, and knowing the fraction number is very important, especially as a student, but also when you start working as a qualified radiographer. This is because when a patient comes in for treatment, they might describe some of their side effects. So, for instance, they might describe that they losing weight, or they're experiencing lots of fatigue, or there's some changes in their bowels or bladder, and you need to understand what fraction they're in, and that would ultimately dictate the type of advice you would give to the patient. So for instance, just to give a bit more perspectives into this. So if a patient comes in for the first or second fraction and they tell you right before image matching, they tell you that look, that they are experiencing lots of urinary changes, or they've gone to the toilet a lot more frequently, they're emptying their bowels a lot more frequently, then your question is, what fraction are they in? If they're on the second fraction, we do not expect the side effects of the radiotherapy to kick in just yet. So you may ask your patient, what other treatments are you having, or any other issues or medical conditions that we're not aware of. So we need to sort of ask these questions, but you wouldn't be able to effectively ask those questions unless you know what fraction they're in. So in this case, if looking at this case where the patient has had 11 fractions already, if they came in with any side effect, we do expect them to have those side effects just because they're halfway through the treatment or almost halfway through the treatment. All right, so let's move on to the next bit. So the plan includes perirectal, presacral, and internal iliac nodes, which I'll dive into later on as we are image matching. Okay, and the patient is also having sequential boost to 50.4 grays to the primary tumor and the mesorectum. So a sequential boost means that after the initial wider treatment volume receives its prescribed dose, an additional dose is delivered to a smaller high-risk area. In this case, that smaller higher dose area includes the primary tumor and the mesorectum. So when we are image matching, we need to be aware of that, okay? The patient is also having concurrent oral capecitabine. So concurrent means the patient's having the capecitabine together with radiotherapy, so at the same time as radiotherapy. So that's concurrent. Oral means that it's taken by mouth, and capecitabine is a chemotherapy drug. So more specifically, it's a drug that is converted into the body into 5-fluorouracil, often called 5-FU. So to simplify this a bit more, in rectal cancer, capecitabine is often used as a radiosensitizer, which means that it helps to make cancer cells more sensitive to radiation, so that once we deliver the radiotherapy, the cancer cells are much more likely to die because the capecitabine has made them more sensitive to radiation. So, why does this matter when it comes to radiotherapy? Why do we need to know this before even image matching? Because concurrent chemotherapy can increase the side effects such as nausea, diarrhea, fatigue, and general difficulty in maintaining the same preparation each day. So, if the patient is required to drink water, it can impact the ability to prepare for their treatment. And the side effects can influence patient positioning, internal organs filling, comfort on the couch, and reproducibility. So it's very crucial that we are aware if the patient is taking any chemotherapy tablets. And it becomes, I think it's very important. This is a very relevant note because if we look down, the note says that the patient has avoided eating during the weekend due to increased nausea and diarrhea. This is very important because nausea means feeling sick, like you may vomit. Diarrhea means frequent loose or watery bowels, and both of these can directly affect the pelvis anatomy. They may change the bowel feeling, the gas pattern, the hydration comfort, and the way the patient lies on the couch. So that takes us directly into the concept of clinical decision making. Because clinical decision making in image matching means that we do not only compare the structure mechanically, so we're not just looking at the anatomical position of it, but we are combining the image appearance, the treatment intent, the plan type, the target volumes, the patient current symptoms, and the likely dosimetric impact of any mismatch. Okay, so let's get straight into the image match now. Hey guys, sign up to Radbod if you want to see many more cases just like this. Sign up for free and start practicing today. Thank you. So first things first, I'm just going to click the information in order to have a better understanding of the training protocol. So each department has its own protocol, and I'm currently using Radbod, which is a website where students can practice image matching. And in this protocol, we've got a vert, long, lateral, and we have a maximum displacement of 2 centimeters or less. So what that signifies is that after image matching, we should have a look at the vert, long, and lateral, and it should be no more than 2 centimeters. Now we can auto match. So what does auto match mean? Auto match means that the system can automatically match based on the bony structure. So it looks at the bony structure from the CT or planning image, and it looks at the current bone structure of today, and it tries to match it together. So let's have a look here. So I'm just going to click auto match, and we are only focusing on the vert, longer lateral, so freed off, 3 degrees of freedom. And I'm just going to adjust the area of interest. This is because if I leave it like this, it includes the black region here, and that impacts on how effectively this auto match can be done. So I'm just going to reduce the size a bit more, so that's fine, and I'm going to get it as close as possible to the coccyx here. It's good. Moving on to the other viewing planes, I'm just going to bring this down a bit more. Yeah, so that's fine. And I'm going to get it close to the coccyx as well. And here I think we can get it a bit closer now. Perfect. So that looks a lot better now. And we've got it in the right position, and we can click apply. Okay, so the auto match is done. We've got 0 on the vert, long we've got 0.3, and lateral we've got 1.1. So ultimately this does not define how the end result should be, but it's a good starting position. Okay, so we've done the auto match. Now we can scroll through those images and double check everything is covered. So first things first, let's just quickly have a look at the current contour structures. So we have different colors here, and it's very important to know what is what. Okay, so let's click here, structures. Okay, so we've got PTV 45, we've got PTV 50.4, we've got bladder, CTV boost, CTV 45, GTV bowels and body. So GTV stands for gross tumor volume. This is the visible, known or palpable tumor seen on the imaging or examination. And then CTV stands for clinical target volume, and this includes the GTV plus any area that may contain any microscopic disease. And then CTV45 will be the clinical target receiving the lower prescribed dose region, likely including the nodal coverage and the broader area at risk. And then we've got CTV boost. Now, CTV boost would be a smaller, with the smaller boost clinical target volume relating to the primary tumor and mesorectal area at the higher risk. And then we've also got PTV45, which is the planning target volume for the 45 gray phase, and PTV 50.4, which is the planning target volume for the boost phase at 50.4 grays. Lovely. So these are very important because obviously when you're image matching, you want to make sure that we're actually covering within the PTV 50.4, which is the boost, and also the PTV 45. We want to make sure that we are covering an area of interest within these structures here. Okay, so now that we're happy with this, we can close that. And what I'm going to do first is to scroll through all the images just to double check and just to have a clear understanding of what's going on. Right, so I'm just going to scroll through. And just for anyone that's watching, can you guys visualize already what's happening? What are your thoughts right now? So I'm scrolling through this. Is there anything that you're currently seeing that is worth noticing? So I'm just going to switch here. Is there anything that you're currently seeing? Yes, that's correct. So we can see that there's a clear contour difference. Yep, that's really good. And I'm just gonna go through this sagittal plane. Yeah, so there's a contour difference here, which may be an indication of weight loss. So as we did mention earlier, the patient did not eat during the weekend, and they've had lots of bowel motion, which could explain why this patient has contour change here. Right, and is there anything else you can notice? Absolutely. So on the inferior edge of our body, you can see that the legs are sort of coming off in a different direction, and that could signify that the patient might be in the wrong immobilization equipment. So for instance, it looks like they might have used a low knee rest for this patient, but then maybe in today's image the knee rest could be a high knee rest, which is pushing the legs in a completely different position, as we can see here. So I'm just going to quickly click and drag here. Let's have a look. Yeah, so you can see that it's completely different from the initial body contour. So the body contour here. Right, so today's image and CT image, very different. So already we've got two red flags. One, there's a contour change, and two, the patient's legs may not be in the right position, and three, there's also one more. Can you think of it? Yeah, that's correct. So the patient is also rolled. So as you can see, the patient was laid straight on the couch, but then on today's image, the patient is rolled heavily. So you can see that the patient's body is sort of rolled towards the left. Okay, so we need to adjust the position there. Okay, so we've got three red flags already before even image matching. Right, so initially when we looked at the patient's case, we saw that we've got the patient avoided eating during the weekend due to nausea and diarrhea, and we can already see that there's contour change and the patient's rolled, and also that we might not have the right equipment on the bed. So that's already a red flag. That's before even image matching. Hence why it's very important to look at all your clinical information before image matching, and that gives you a better understanding of the current situation. What most students would do is to have a look at what most students would do is to just have a quick glance of at the patient information, and they would try to image match, knowing damn well that we've got three red flags and the patient is not in the right position to even have treatment. And as we mentioned earlier, we are proceeding with the VMAT plan, which means that any changes in anatomical position and any contour difference can severely impact on the dosimetric effect of the treatment. Hence why, by just a first glance, we can safely say that we can take the patient off the bed and we can reposition them. So double check the setup equipment, make sure that we've got the right equipment, and we'll get all the images sent to physics for dose assessment. And in radiotherapy, physics are professionals who assess the dose distribution, treatment accuracy, and the technical plan, the technical impact of the plan. And if there's any concerns that the anatomy or the position has changed enough to compromise the intended dose, physics may assess whether the current geometry would still deliver an acceptable dose, or whether the plan may require further adaptation. So in this instance, it's not ideal to treat the patient. So I've not even gone to image match, but I already got enough information to tell me that, look, this image is not ideal for us to proceed treatment with. So I think it's ideal to take the patient off the bed, double check the equipment, make sure that we've got the right equipment, send the images to physics to conduct a dose assessment, and potentially refer the patient to a dietitian. Okay, so I'm just going to click don't treat. We have the correct decision, and that's because the patient is rolled to the left plus contour change present. So lower limbs also appear more anterior than on the planning reference image, raising concern that the patient may not be positioned in the correct knee rest. Although the image match suggests acceptable target coverage, this is a VMAT plan, and both the contour change and rotation variation might affect the delivered dose. Recommended correct and pelvic rotation by rolling the hips to the right, then re-imaging. Images should then be sent to physics for a dose assessment, and then consider referral to dietitian to help minimize further contour change. So in this video, you've seen how it's very important to review those images and to review all the information that you can have in order to conduct the most appropriate clinical decision making. So what most students fail to do is to look at all the important information, so they will just jump in straight into image match and attempt to match the images together, but you're failing to understand that there's a lot more to it. There's a lot more information that we need to take in order to match the images appropriately. Now, in this perfect example, we saw how all the information the information that we've gained prior to even image matching has already told us that, look, this patient is not ideal to treat right now with this image.